Hi everyone, this is Mahip and I'm calling in from New York. It is such an honor to be able to speak at this webinar today, and I'm excited to share my research and perspective on the management of pancreatic cysts and really contextualize it as a condition that predominantly affects older patients. And it was a real privilege to be able to publish this work in the journal Current Treatment Options in Gastroenterology this past fall in the September 2024 edition. And with that, I'll get started. So I think perhaps we've all appreciated that in the past decades, we've increasingly found pancreatic cysts identified in the radiology report of scans ordered for a variety of indications. And what it really means is that, the first providers that are realizing that a patient has a pancreatic cyst are often ED providers or primary care physicians who've ordered abdominal CTs and MRIs for a variety of different reasons. And pancreatic cyst is an umbrella term that encompasses many different types of cysts, including serous cystadenomas and mucinous cystic neoplasms and cystic neuroendocrine tumors. And all these various cyst types differ in their epidemiology and their risk of progression to pancreatic cancer. And the most common pancreatic cyst type is intraductal papillary bucinous neoplasm, or IPMN. And the IPMNs are really going to be the focus of my talk today. And so IPMNs are further categorized in a variety of different ways, most often in terms of main duct versus branch duct IPMN, kind of describing whether the IPMN is found in the main or a side branch duct of the pancreas. And this is relevant because main duct IPMNs tend to portend a higher risk of malignancy. And then, of course, pathologically, we classify IPMNs according to their degree of dysplasia, ranging from low-grade dysplasia all the way to invasive carcinoma. But truth be told, the field is still in its infancy in terms of elucidating the natural history of IPMNs. We still don't quite know what are the characteristics of a particular IPMN that are associated with progression from low-grade to high-grade to invasive carcinoma, and what the timeline of that progression is. Does it happen consistently across all patients? And so that remains a very active area of research. And the current middle ground we have in terms of trying to mitigate the extremes of premature and delayed treatment is that optimally we would resect IPMNs that exhibit high-grade dysplasias. So we're avoiding resecting IPMNs that have low-grade dysplasia because we don't know if they're really going to progress. And of course, we want to intervene before we reach the stage of cancer. We have seen a number of research efforts that have sort of established a correlation between the prevalence of IPMNs and increasing age. And autopsy studies often report that the incidence of pancreatic cysts in those studies is up to 50%. And of course, that means that patients with IPMNs have many interacting health conditions. Older patients have a higher likelihood of multimorbidity, and so it's worthwhile to consider how do we weigh the risks and benefits of IPMN surveillance in this patient population that has many competing health conditions. And a variety of organizations around the world have established guidelines to inform surveillance and intervention on IPMNs, including the International Association of Pancreatology, the American College of Gastroenterology, the American Gastroenterological Association, the European Study Group, the American College of Radiology. And these guidelines differ slightly in how they risk stratify IPMNs and the particular imaging or clinical features they use to stratify IPMNs, as well as the exact surveillance time intervals, but they are unified in recommending against surveillance for patients who are not surgical candidates or otherwise have a poor prognosis. And kind of, given the reality of the patient population with IPMNs, there have been more and more studies that have tried to focus on outcomes for patients with IPMNs and stratify outcomes according to patient age, comorbidities, and cyst risk. And when I say cyst risk, one way of thinking about it is, as I mentioned, the main duct versus side branch approach. And the International Association of Pancreatology, the IAP, for example, recommends resection for all main duct IPMNs. But when it comes to the branch duct IPMNs, There are clinical and imaging features that are used to sort of characterize, is this a high-risk cyst versus a lower-risk cyst? And for example, per the IAP, high-risk stigmata include obstructive jaundice, a pancreatic duct dilated more than 10 millimeters, and an enhancing mural nodule that's larger than 5 millimeters. And those are kind of factors that say that that is IPMN with high risk and perhaps should strongly be considered for intervention. That being said, most patients have branch duct IPMNs, and in studies, cohort studies following such patients, the rates of pancreatic cancer are low in the single-digit percentages, and most deaths in these patients are non-pancreatic cancer related. And perhaps even more precisely, a recent meta-analysis of 18 studies found that, focusing specifically on lower risk cysts that exhibit size stability for the first 5 years that, the patient is being surveilled, the rate of invasive carcinoma advanced neoplasia is 0.2% patient years. And I think this growing data informed the most recent update to the IAP guidelines for pancreatic cyst management. And they now provide the option to stop surveillance after 5 years of stability for smaller IPMNs that don't have the aforementioned high-risk features. More broadly, there are still kind of a variety of things to consider in the IPMN patient population. For example, frailty is a concept that is increasingly being studied in other gastroenterologic conditions, including IBD and cirrhosis. And frailty is really the concept that independent of age, certain individuals are going to have decreased functional status and kind of physiologic strength that affects their ability to withstand certain procedures and treatments and just their overall lifespan. And IBD and cirrhosis are kind of relevant to kind of compare to IPMNs because of the similar patient population of it being a predominantly geriatric patient population. Oftentimes, and for these conditions, there have been kind of frameworks thinking about, for example, the 5 M's of gastroenterology, and considering medications, mind, mobility, multi-complexity, and what matters most for older patients, and so seeing as these frameworks have been applied in IBD and cirrhosis patients, I think that increasingly pancreatologists can sort of take those various frameworks into mind to think about how do we best navigate decisions surrounding surveillance and interventions for patients with IPMNs. And overall, I think the goal, like for any condition in medicine, is to really establish an individualized management plan. And so the framework that myself and my mentor proposed in our recent article is a patient-centric approach that takes into account kind of 3 major buckets when crafting a management plan for a patient with an IPMN. So it's patient characteristics, which of course can include age, the various health comorbidities that they have, and frailty, and there's growing research on various frailty scores that could be applied in this patient population. Then of course patient preference, which maybe is the first bucket to consider, and that's what are the goals of care for the patient, what do they prioritize at the current stage that they're in, what's their support system to kind of go through process of the stressors of surveillance, and would they be willing to even undergo any sort of intervention for the pancreatic cyst. And then the last thing, really focusing more on the cyst, is how serious is the cyst? What are the imaging features of that cyst, the clinical symptoms associated with that cyst, and really, from what we can best predict, what are the odds that cyst is going to progress to pancreatic cancer? And I think it's often great to have a multidisciplinary clinic that patients can visit when they're being followed for pancreatic cysts that includes medical oncologists, gastroenterologists, advanced endoscopists, and hepatobiliary surgeons who can all sort of weigh in on an optimal plan from their perspective for a patient and engage in that shared decision-making process to decide whether they want to follow have that cyst followed and continue surveillance, whether they want surgical resection, or whether they may know that they have a pancreatic cyst, but they're not interested in following it through. And I think hopefully as we advance as a field in terms of our ability to risk stratify pancreatic cysts, that will be very valuable and help guide some of the choices that sometimes are difficult to make in the face of uncertainty, as well as we get more data on how various patient characteristics affect outcomes for patients with IPMNs, including kind of the impact of frailty, for example, and generally doing more research on what is the burden of surveillance for patients with IPMNs, what are the detrimental effects of the anxiety it comes with, and then what are the positive effects in terms of preventing pancreatic cancer and being able to intervene on a subset of pancreatic cancers earlier. That's sort of my current take and something that I have really enjoyed doing a deep dive into. Thanks all very much for listening.